Hi everyone, and welcome to Griffin Professional Development's Canine Medicine Modular course. Today's module is going to be on the subject of hyperadrenocorticism, otherwise known as Cushing's syndrome. So first of all, we have to consider how Cushing's comes about, and should remind you that the reason it's called Cushing's syndrome is because it was first described by Dr. Harvey Cushings back in 1932, so it's still a relatively recent disease that's been identified in small animal patients. And it's associated with an excess of cortisol production from the adrenal glands. Now, the adrenal glands have three distinct layers. I'm going to try and be technical here and see if I can show you the mouse on the screen. Hopefully that's working. So we can see on the right-hand side of your screen that there are the three layers of the adrenal glands, and each layer produces different hormones. So the zona glomerulosa at the top here, that produces mineralocorticoids. The zona fasciculata is mainly associated with production of corticosteroids, and the zona reticularis is mainly associated with the production of sex hormones. So there are two forms of hyperadrenocorticism, both spontaneous and iatrogenic. Iatrogenic is when we've caused it by administering glucocorticoids parenterally or topically, and obviously spontaneous is the clinical disease. Spontaneous hyperadrenocorticism is most commonly associated with a functional pituitary adenoma, very rarely a carcinoma, and this secretes excessive quantities of ACTH, which then stimulates the adrenal glands to produce excessive quantities of cortisol. About 90% of cases with pituitary-dependent hyperadrenocorticism will have a detectable pituitary tumour if advanced imaging is performed. Adrenal-dependent hyperadrenocorticism is the other type of spontaneous HAC, and we usually have a functional adrenal tumour which is autonomously secreting cortisol. These, once again, may be functional adenomas, but from time to time we will get carcinomas. And if you are identifying a large adrenal mass on either ultrasound or advanced imaging like CT, if the mass is greater than 2 centimeters in diameter, it's probably more likely to be a carcinoma. So spontaneous hyperadrenocorticism is associated with either being pituitary dependent in about 80 to 85% of cases, and this is more typically identified in small breed dogs, whereas it's less commonly associated with adrenal dependent hyperadrenocorticism in about 10 to 20% of cases. And these can be either functional adenomas or potentially carcinomas. But finally, if you have performed a lot of investigations and haven't identified any changes within the adrenal gland that makes you suspicious of an adrenal tumour, or if you've done advanced imaging of the brain and not identified a pituitary mass, it could in fact be an ovarian tumour that's producing cortisol-like compounds. We also need to discuss iatrogenic hyperadrenocorticism, and this is where we've caused the symptoms of Cushing's syndrome, and this is due to chronic use of glucocorticoids. Now, you may assume that this is only associated with parenteral administration of glucocorticoids, such as prednisolone, but that's not the case. It's also associated with chronic use of topical glucocorticoids, so that includes ear preparations, skin creams, and eye drops. So if you have an animal with overt signs that you would associate with Cushing's, but it's got a long-term history of skin cream administration containing steroids, or perhaps even ear or eye drops, you do have to consider that the reason for that may in fact just be due to the medications this dog is receiving. The signalment, in all medicine cases, we're using kind of pattern recognition. So the signalment is always important to us to help identify which animals may be more likely predisposed to one condition versus another. But for Cushing's, it can occur in pretty much any breed of dog, but the terriers, poodles, and dachshunds may be more commonly associated with Cushing's syndrome. And as far as the adrenal-dependent hyperadrenocorticism is concerned, as I've mentioned before, it's more common in large breed dogs. So pituitary dependent, more common in small breed, and adrenal dependent, more common in large breed. But there's always going to be a crossover, but pattern recognition is important. These dogs tend to be middle-aged to old-aged, and dogs with adrenal dependent hyperadrenocorticism do tend to be slightly older. Cushing's has been diagnosed in dogs from as young as 6 months to 20 years, but almost all dogs with hyperdrenocorticism are going to be older than 6 years, and the vast majority greater than 9 years. So I would advise you against endocrine testing in dogs that are younger than 6 years of age, because the chances of it being Cushing's are relatively remote. Of course, there's always the exception that proves the rule, but as a general rule, the vast majority of patients are going to be greater than 6, and most, in fact, greater than 9 years of age. And there may be a slight female predisposition, about 60% female to 40% of males. The prevalence of Cushing's syndrome is thought to be about 1 in 100 dogs, but this study was completed at a referral hospital, so it might not be representative of the typical population that we're seeing in small animal practice. And the clinical signs, well, I'm sure we're all very familiar with them. The clinical signs, the most important in my experience is PUPD, so polyuria polydipsia. That will be present in 90% or more cases of animals presenting with hyperdrenocorticism. And the reason we get that is because the condition itself interferes with the action of ADH, and so that therefore has an impact on the renal tubules, and the animal can't reabsorb water from the renal tubules, effectively causing a polyuria and a subsequent polydipsia. So Cushing's is about all the P's. We've said PUPD. We also have polyphagia, an increase in appetite. We have panting, and that's usually associated with weak muscles, such as the weakness of the diaphragm or weakness of the intercostal muscles associated with the cortisol excess. We also have a pot belly. That too is because of muscle weakness and the liver being enlarged and sliding down ventrally in the abdomen. We also tend to have skin changes with a symmetrical truncal alopecia. And we often will have comedones or blackheads on the ventral abdominal skin. And as I previously mentioned, if you palpate these dogs' abdomens, the liver is typically enlarged. So we have a hepatomegaly, and that contributes to the pot belly. So the signs are caused by excess cortisol, and the signs are present regardless of whether it's pituitary dependent or adrenal dependent. The signs are the same. And the alopecia we have, as shown in the diagram you have here on your right-hand side, tends to be this kind of truncal alopecia. We've got what appears to be very sparse hair coat here. We've got areas of alopecia here. And the alopecia tends to spare the head and the limbs, and it's mainly a truncal alopecia, and we have a much higher instance of pyoderma in these cases. The skin may also be thin. We may have evidence of calcinosis cutis, and also increased pigmentation. It does look to me from this picture as though there might be some little areas of calcinosis cutis here, but I've got some more pictures of that for you shortly.